Thank you very much, Mike, and I want to thank all of you for turning out. I see an awful lot of friends. It is remarkable to me how many people are interested enough in healthcare that they'll get up early on a cold winter morning and come out and listen to someone speak on the topic. It's a big topic, and I think I do need to be careful about how much of it I try to inflict upon you this morning. I'm reminded of the story of the circuit riding preacher in Vermont who rode into a small town and went to the little church and waited for the service to begin, only to find that as the time arrived, there was only one parishioner. He thought about it for a minute and went and talked to the parishioner, and the parishioner turned out to be a farmer. And the farmer said to him, well, he says, should we have a service? And the parishioner said, well, you know, I go down to the back pasture to feed my cows, and there's only one there. I feed her anyhow. So he goes up and he starts off with a hymn and a prayer and a benediction and a rousing sermon and a homily, another hymn, another prayer. Wraps up about 2 hours later, and goes out to the door to shake the fellow's hand, and the fellow comes by and he says, listen, he says, go down to back pasture to feed my cows, and there's only one there. You know, I don't give her the whole load. So this morning I'm going to try to avoid giving you the whole load. The last time I spoke, let me see if I can get this clicker right. There we are. Last time I spoke was 2005, and that was, for those of you who don't remember, the year that the Patriots won their third Super Bowl. We thought they could never lose. They certainly haven't upheld that, have they? The stock market was going only upward. That certainly hasn't persisted. And avian flu was terrifying all of us. That has sort of faded into our background. But one thing that hasn't changed is the issue of rising healthcare costs. If you look at the left-hand side of this graph, those gray bars that you see there speak to the history, which is about between a 6 and an 8% annual increase in the total cost of healthcare for a family. The set of bars to the right are actually projected costs at a 3%, 6%, and 8% rate of increase. That red line at the top is family income. And as you can see, if we proceed along at the 6 or 8% clip, we could consume between half and 2/3 of people's family incomes on health care within the next 10 years. That obviously is not sustainable. And it's a bigger problem because it's a huge component of federal, state, and municipal budgets. You take health care costs out of the federal budget, and our budget woes go away overnight. And it severely affects the competitiveness of companies, particularly companies here in Maine, where we've got a lot of other geographic and resource challenges. It displaces other important investments: education, infrastructure, roads and bridges, economic development. Think about this. In Europe, across Europe, 10% of their GDP goes to health care. In the United States, it's 16.5%, and in Maine, it's 21%. That is a big number. And as the economist Herb Stein once said, if a trend can't go on forever, it won't. This is going to stop in one way or another, and we can either design how it stops, or it can come crashing down on us. If we try to break apart what's really going on here, the first thing that I find striking, and this I was really given a nice gift by the people from the Washington Post this weekend. I was thinking, I don't have a really good way to show the disparity of unit costs in the United States versus the rest of the world. But we have extremely high unit costs for services here in the United States. And as you can see here, a C-section's a little bit more in this country. A cost per hospital stay is actually about twice what it is in the highly advanced industrialized countries of Europe. Angioplasties, hip replacements, and coronary artery bypass grafts, dramatically more expensive here than they are anywhere else in the world. The same thing holds for doctor visits, pharmaceuticals. Those pharmaceuticals that you see advertised on television sell in this country for approximately twice what they sell for in the European countries. It is a big issue. The next issue is that of quality. And this graph, which I want to be careful, it can look like a sort of inside baseball conversation here, but this is a graph that shows actually the frequency of hospital admissions for the populations of different areas. And it comes from the Dartmouth Institute, who studied a wealth of different services. But if you take a look, southern Maine actually isn't bad, it's light brown. Northern Maine is dark brown. It's the same rate of admissions that we see in Massachusetts. And we see these kinds of variabilities across a wide number of services. That variability tells us that the processes and decisions in different areas, because these populations aren't basically different, the people aren't different. What is different is the way in which we practice, the way in which we care for people. This is the macro picture of that, but you see it when you go to two physicians and get two different opinions for the same presenting condition. It is an area of absolutely crucial quality improvement necessity for our profession and our industry. What we see happening is a few places that are beginning to get their arms around it. Intermountain Healthcare in Salt Lake City, led by a really superb physician leadership. The Virginia Mason out in Seattle. We do it at some micro levels at Martins Point, which we'll talk about in a little bit. But the fact is that these wide variations in how we provide care really represent a compromise of quality and engender enormous cost. Furthermore, since I spoke last time, some other issues have really raised their heads. And, the three big ones here are, one, that we're getting older as a population. Maine is one of the oldest states in the country. The fact is that we really can't do much about that. We're going to all live as long as we can, aren't we? But what we realize is that older age is associated with increase in healthcare costs, and it is being supported by a smaller and smaller younger population. There are some things that we can do about it. We're discovering that fitness and wellness in the elder population lead to less illness, less hospitalization, less challenge for them in terms of their late life. But this is really a problem about which we can do relatively little. The second is that of population health. We have many more chronic health problems than we had just 6 years ago when I spoke here. Obesity is a great example because it has a whole downstream set of issues. We are exercising less, we're eating more, we're sitting in front of screens more, we're driving rather than walking. And if you look at this chart, you see the astonishing fact that we have gone in 15 years from 15% of Mainers who are obese, and when we're talking obese, we're talking body mass index over 30, I mean, we're not talking a little overweight, to 25%. That has as a consequence that we're seeing much more type 2 diabetes and earlier, and the consequential cardiovascular issues as well. The third and final fundamental change that we're seeing from a healthcare perspective is our economy really has consequences for health. In Maine, as we know, one in 6 people are or underemployed. 1 in 6 people live in poverty. Those two phenomena lead to significant less access to primary care, lack of preventive care, poor living conditions and stressful environments, nutritional challenge, substance abuse, and consequently lead to considerably more healthcare costs. Our economic development issues are also related to our health issues. This graph, which comes from Dr. David Kindig, who is a professor of population health at the University of Wisconsin, shows health outcomes, and the light areas, like Cumberland County, are places where we have the best health outcomes. The dark areas are the places where we have the worst health outcomes. And if you superimposed an income graph over this, you would see that the places where we're having the worst health outcomes in the state, the place where we're engendering the greatest health care costs, are also those areas where we have the largest economic challenges. There has been one more big fundamental change that has occurred since I spoke in 2005, and that is the passage of the Patient Protection and Affordable Care Act, also known largely by people who don't like it as Obamacare. That is going to have three consequences, I would posit, if you try to boil down this incredibly complicated act into just a few tight bits. The first is that if the individual mandate is upheld by the Supreme Court, and there are quite a few people who believe that it will be, it will move us to 90 to 95% of individuals have insurance coverage. It'll happen through a variety of means. Employers will have a mandate. Medicaid and Medicare will be expanded, and health exchanges will be put in place to sell individual coverage for people who are unable to access care in other ways. The second thing that will happen is that the regulatory environment for health insurance companies will be vastly changed. And I think you probably know of some of these facts, but what we know is that in the Affordable Care Act, insurance companies have a mandate that they will have a medical loss ratio. The amount of money they spend out of care, as opposed to their entire premium, will be about 85% for most business, 80% for, I believe, small group business. Another big piece of their regulatory environment is that they will have guaranteed issue. Lifetime limits go away. And for the health insurance community, this becomes a much more adverse environment than what we've seen in the past. And lastly, and sort of out of people's sight in this act, is an enormous amount of effort to improve the quality of clinical care and to get health systems to assume both clinical and financial responsibility for the care of populations of people. And this, the instrument that is most visible is called the Accountable Care Organization. These organizations are being founded for the purpose of essentially building systems of care where people can move through the care system in an orderly and thoughtful way, where you can build standards of care, where you can measure those, and where the delivery systems will become accountable for their clinical and for their financial results. What is this going to look like in 5 years or 10 years? Well, there are observers. Zeke Emanuel at NIH, for example, who is Rahm Emanuel's brother, has written about the fact that he believes by the year 2020 that health insurance companies as we know them won't exist. I was really struck that Mark Bertolini, the CEO at Aetna, is saying the same thing. He sees them as fundamentally changing their role into support entities that are supporting these ACOs by providing them with data and financial intermediary services. But the risk models and the kinds of insurance companies we've seen are probably going to change in a very fundamental way. So what can we do here in Portland that will change the trajectory of healthcare costs? We've thought a good deal about that, and I would say that there are certainly 4 things that stand out front that we can do. The first is integration of care. How do we bring the care together so that when you go to the specialist and then to the hospital and then home and you're seeing 3 physicians and you're taking 10 medicines, that everybody knows what everybody is doing and that there is really good understanding of that. The second is to create incentives and information for providers to direct patients to the most efficient care, including preventive care. There is, for example, an imaging study that you can get in a 25-mile radius of here, done with the same manufacturing machine, the same tool, read by the same doctors, that you can get for $500 or for which you can pay $2,000. And it has not been transparent, and physicians have not really had any reason to help people to find lower cost. We can also provide information and incentive for consumers to help them to seek value. And the last thing that we can and must do is reduce poor health behaviors that increase the risk of an adverse health event. These are the things that we are really taking on at Martin's Point. Who are we and who do we serve? What exactly is Martin's Point? Martin's Point is a not-for-profit healthcare organization. We were founded on a campus, by the way, that was the Marine Hospital, founded in 1859 to care for sailors who were left here. Remarkably, care has been delivered on that campus for 152 years, continuously now. And we do two things. The first is that we are ardent believers in the power and value of excellent primary care. And we operate 9 health centers. We have one in Portsmouth and one in Bangor. The rest are concentrated in the greater Brunswick area. They are primarily primary care centers, although we're slowly adding specialty care to integrate the care processes between primary and specialty care. And we are a health insurance provider. We provide health insurance to military retirees and their families. There aren't as many of those here, as you could imagine, as there were 10 years ago when we had greater base presence, but we've expanded out now and offer those services in places as far afield as the northern tier of Pennsylvania, Buffalo, New York, Fort Drum. We offer a Medicare Advantage program for seniors and other Medicare eligibles called Generations Advantage. And we are now providing, in partnership with the Maine Wellness Association, a product for small and medium employers, which I'll talk a little bit more about in a minute. We serve roughly 72,000 patients. We have about 55,000 plan members. And we have now 850 employees, up from 350 last time I was here, in 5 states. At Martin's Point, we really keep an interest on 3 guiding forces. We manage 3 things simultaneously. We focus on managing health outcomes, we focus on managing patient experience, and we focus on managing the total cost of care. And we believe these things can be managed simultaneously in the interest of our patients and in the interest of the community. To give you just a picture, improving health outcomes, here we have one of our wonderful internal medicine doctors, Dr. Doug Cooper. He has a population health focus. He knows who he's taking care of. He has a list of patients, and if they don't come in, he's tasked with pursuing them proactively, identifying their risks, and taking a systematic approach to managing their care. Doug, if you go by his office, has outside his door a control chart that shows how many of his patients have their hypertension under control. And he has really built a coherent, consistent system of care that he shares across the organization. We are doing that as well. We're beginning that same work with other areas of risk, such as cholesterol management, obesity management, and tobacco use. The second thing that we really focus on is improving the patient experience. You know, really nobody seems very happy with their visits to the clinical system these days. And we really have been focused on that for the past several years. And the way we've done that is to put in place the patient-centered medical home. It is unique in that it builds care through team work. These teams are doctor-led. They use nurses, medical assistants, and other staff on the team. Even includes the people that answer the telephone, because it's really important when that patient calls in that they recognize the voice and the person on the other end of the line. This model helps us to know our patients better. It helps us to listen to them in partnership better, and it helps us to better manage and coordinate their care. We were delighted that we were featured in a 2010 NPR story on the medical home and the movement toward primary care medical home. Their quote from us was wonderful. Imagine a place where your doctor doesn't keep you waiting, does keep you healthy, and works with a whole team of other healthcare professionals. Oh, and imagine that place makes the doctor's life easier and healthcare cheaper. I'd love to tell you we were done. We've got a long way to go, but we're well down that road. And lastly, managing the costs of care. And we really have been thinking a lot about this. We moved our approach to payment for primary care away from a fee-for-service model and toward a model that rewards people for performance. We compensate physicians for activities that have not traditionally been compensated: telephone calls, emails, for looking at the care of the entire population. And we really support the team-based care phenomenon. Introducing MainSense. Let me tell you a little bit about MainSense. This is a product that has been that began last fall, has been widely available since January of 2012, and it was developed in partnership with the Maine Wellness Association. The Maine Wellness Association is a health insurance company comprised of over 100 leading Maine Maine-based employers working together to improve healthcare systems. And what I would tell you about them is that these are Maine companies, many of them multi-generational, with a very high standard of caring for their employees and a true sense of responsibility. And if you look at what they've taken on the challenge of care fragmentation by requiring that people have a primary care physician. We select those primary care physicians. We incent people to use primary care physicians that are highly ranked through the Maine Health Management Coalition Pathways to Excellence project, a really terrific project the Maine Health Management Coalition has done. And we really work at using practices, encouraging people to attend practices that coordinate their care. We have worked with employers to deal with the issue of lack of knowledge about cost and quality, using website with easy access to to quality and cost information. We have really begun to work on the issue of how do we incent people to think about the total cost of care. And one way we've done that is through healthcare savings accounts programs, funded healthcare savings accounts, and the One Bill, which I'll show you in just a minute, a really cool innovation of this MainSense program. There is an enormously energetic effort to improve employee wellness. You know, there are wellness programs, employer support for screenings, education, really strong incentives for employees to manage their health. And lastly, dealing with system costs through working to pay for value and not to pay, as we have in the past, for volume. As we think about the One Bill, I just want to give you a sense of this innovation. How many people in this room have received this thing that says, "This is not a bill, explanation of benefits," where you receive a document that frankly is absolutely unintelligible? All you know is that you don't have to write a check. This project, which the Maine Wellness Association demanded from us, and thank God they did, is a project in which each month, each family will get a single document that lists all of the services and goods that were provided in the course of that month, and how much they cost, and what their financial responsibility for those are, with a single check that can be written for that. I will tell you, the first time that reached my mailbox, because we do eat our own cooking, the first time that reached my mailbox, I was blown away by how much of Martin's Point's money my family and I were spending. And I believe all employees are going to be profoundly affected by that as they make their decisions. For more information about MainSense, you can go to this website, www.mainsense.org. On a personal note, I am one of the luckiest people I know. I had the wonderful fortune to be brought up in a family on Cape Cod with my dad is that upper left fellow. We're coming in from a day of striper fishing. He was an old Cape Cod country doctor. After I graduated from medical school, I was also delighted to find that he was a fantastic physician. and he deeply influenced my direction. I was lucky to be able to go to Dartmouth and Dartmouth Medical School, where I became aware of the issues of variability, the distressingly inconsistent processes that we use for care, and to get a head of energy for that work from that education. And I am incredibly lucky to be working at Martins Point with 800 of the best people I know working to change Maine health care.